Hello folks, I'm Isai with Learn NCLEX Now, and today I'm going to be discussing ICP. So to start off, I'm discussing intracranial pressure. Okay? And intracranial pressure is when the brain begins to swell, or there's something that's within the brain that's increasing in size or in fluid volume, and it increases the pressure within. This can be caused usually by some type of head trauma. We're talking about things like traumatic brain injuries secondary to car accidents, or maybe the patient fell off the bed with a significant force that it caused ricocheting or moving around of that brain within the skull, within the cranial vault, and it causes swelling and edema and perhaps bleeding. So that's usually the main culprit behind ICP, but we have other secondary issues like hemorrhagic strokes, or just general bleeding in the brain. Okay, we can also, it could also be attributed to things like tumors, okay, or other elements that just increase in space, in mass, in volume within the cranial vault that prevents the brain from expanding more, because what do we have? We have the skull, the cranium, and that limits the expansion of the brain, or the swelling of the pocket of blood that's increasing within the cranial vault. And that's going to lead to an increase in ICP. There's a lot of clinical manifestations that you guys got to be familiar with, but instead of memorizing the plethora of clinical indicators of ICP, let's discuss something called Cushing's response, or Cushing's Triad. Now, Cushing's Triad should not be confused with Cushing's syndrome, which is an endocrine hormonal issue. Two different things. Cushing's Triad is discussing the three main clinical manifestations that you're going to be noticing with your patient when they have increased pressure within the brain, within the cranial vault. And so, since the brainstem is normally responsible for your blood pressure regulation, the vasomotor response, or the vasomotor locations within the brainstem, for your, we have baroreceptors. And these baroreceptors are located in the aorta and in the carotid arteries. And what they do is they continuously communicate with the brain and let the brain know, hey, this is what the blood pressure is like right now. And based on that information, the part of the brainstem will send a signal to either vasodilate to reduce blood pressure, or vasoconstrict to increase blood pressure. So there's consistent communication between the brain and the vessels throughout the body to regulate that blood pressure. We also have centers for vital signs in general. So when you think about the brainstem, what you guys should be thinking about is vital signs, excluding temperature. Temperature is controlled by the hypothalamus. However, as metabolism increases, the hypothalamus is what regulates the temperature. As the temperature increases, metabolism will also increase, and that will directly affect the ICP, which I'll discuss in just a little bit. So moving along to what I was discussing with the brainstem and baroreceptors and vital signs, that's what's going to be the main issue that's going to be manifesting in your patient. Okay, you're going to see just drastic changes in blood pressure, in heart rate, and in respirations. So let's talk about those first. The first one we're going to discuss is bradycardia. Bradycardia is the decrease in heart rate. You guys ever hear that a child hits his or her head, or somebody hits his or her head, and they always say, don't let them fall asleep? That's because as the brain swells, the centers of the brain that are responsible for vital signs, they become affected. And as the pressure increases, your heart rate will drop. And if your heart rate drops significantly, well, then it won't be able to maintain hemodynamic status, it won't be able to perfuse the body, and you may slip into a coma and eventually die. The same thing goes with the next clinical manifestation, which we know as Bradypinia, or the decreased respirations, and this is the same concept. This is why we typically see in movies and in pop culture that if somebody hits their head, don't let them fall asleep, because this is what's happening. The respirations will also decrease, and if the respirations drop below the level as to which they can maintain life support in your body, well, then you're going to pass out, you're going to actually die. So because of that, we have to include bradycardia, bradypinia as two of the main clinical manifestations that we'll discuss in Cushing's Triad, the main clinical manifestations of increased ICP, intracranial pressure. But we also have something called a widening pulse pressure. Now, a widening pulse pressure is when the pulse pressure becomes greater. First of all, let's define what pulse pressure is. It's technically the difference between your systolic and your diastolic blood pressure. So for instance, if your blood pressure is 120 over 80, the difference between 120 and 80, that equals your pulse pressure. So if we go 80, 90, 100, 110, 120, in this particular case, your pulse pressure equals 40. So as it widens, this number, or the difference between your systolic and your diastolic, becomes greater. And that's what we're really looking for. We're looking for trends as opposed to just specific numbers. And so if your patient comes in secondary to a suspected head injury, and usually that happens when the patient can't recall the events of the traumatic event that he or she experienced. Well, let's say at 9 a.m., your patient comes in and his or her blood pressure is 120 over 80. Well, that's not a bad blood pressure, right? It's probably better than mine. But then we're looking at 10 a.m. We assess the patient again. Patient's blood pressure now is 128 over 78. By itself, it's not a bad blood pressure. But what are we looking for? We're looking for trends. So then we assess it again at 10:30, let's say. And at 10:30, it's 132 over 78. What we're looking at now is a trend of a widening pulse pressure. The difference between the systolic and the diastolic is becoming greater. That should equate a red flag. That's something that you guys have to be keen to in your assessment to ensure that Cushing's triad is not manifesting or worsening, which can, of course, cause detrimental damage to the brain and cause your patient to expire. So with that being said, these are the main clinical manifestations, folks, but there's also going to be other neurological factors. For instance, generally speaking, when you flash the pen light into a person's eyes, your pupils will constrict, right, in response to the light. What ends up happening is the brain's being compressed, your cranial nerves, oculomotor nerve is also being affected, and because of that, the pupil response becomes sluggish, okay, as opposed to brisk. So you have to become aware of this terminology as well. This is essentially what's happening to your patient that's developing an increase in ICP. Pressure in the brain is increasing, and remember, it can be secondary to trauma or intracranial issues like a hematoma or any type of brain bleed, which can increase the pressure. Now that we've kind of outlined the issues with the clinical manifestations, but briefly, let's recall that if we're having neurological symptoms, it's also going to lead to potential posturing. So posturing, we're discussing the body's innate ability to contract. This is called the corticate, or everything becomes outward, the cerebrate. Those two are posturing mechanisms that occur because of the compression of the brain that's relaying abnormal conduction throughout the muscular system from the neurons to the muscles, and that's what causes the posturing, the abnormal posturing. So, and to kind of get a better idea as to how the entire level of consciousness is, or their coma status, we utilize a Glasgow coma scale, which I previously mentioned in a previous video. So, with that being said, let's discuss some potential interventions for these.